Hello, everyone. Welcome to Keeping in Touch this week. So, I have a very special guest today. Her name is Dr. Evka Cesnek, and she's having an exciting day herself, and we're going to hear about it. But just to give you a little introduction here, she goes by Dr. Eva. So, Dr. Eva is a medical doctor, an online course creator, and best-selling author. She, like I, has a home visit practice in New York or New Jersey?
New Jersey.
New Jersey. Okay, I was going to say New York, and then I was
New
like, I
Jersey.
think I'm wrong. New Jersey. And she's a family practice physician, and her niche is food allergies and babies with feeding challenges and colic. So very, very relevant to many people. I get questions about this all the time, and I have questions about it all the time because, it's not super straightforward to manage. So welcome, Dr.
Thank
Eva.
you very much. Gosh. And I'm glad you mentioned New York because I'm just in the process of getting my medical license.
Oh,
in
good.
New York,
Okay.
so I can also see people in the city.
Yeah, that's great. That's great. So how long has your practice been open?
Oh gosh. So I've been doing my own practice. I started writing my books 5 years ago, and I have done my own practice for the last 3 years, where I have
Okay.
been seeing patients in their homes.
Okay.
And it's been a journey, but it's been a
Yeah.
journey where what I like about it is when you see people in their homes, you get to spend a lot more time with them. At least I get to spend a lot more time with them.
Sure.
And there's a lot that you learn about people just from being in the home environment.
Mm-hmm.
And that you don't necessarily know about them when you're just seeing them in the office. You can see all their medications. You can see how they live. You can see who they live with, what's going on in the home that's making it harder for them to get medical care.
Right.
Transportation issues that they may have. Who do they
Mm-hmm.
live with? Who's giving them their support? So I think it gives you a lot more of the clinical picture, and having that clinical picture then allows you to be a better physician.
Right. I agree. That's awesome. How is it that you got into your niche? I know, like for me, I got into my breastfeeding niche because I myself had trouble with breastfeeding. So that's how a lot of people find their way, but not everyone. So I'm curious how you found your way to the feeding and colic issues.
And allergies, gosh. So
Yes.
I think we all have stresses in our life. So it's similar to you. And so, gosh, I've had a lot of stressors in my life. Like I was born in a communist country. I was homeless for a bit. I lived in a refugee camp before I came to the United States, where I lived in poverty, and then just like this journey of grit to get to where I am now.
Yeah.
And we all have lemons in our life. We all have things that happen which we don't expect to happen, but they do. And my daughter, when she was born, it was such a blessing. I love her dearly with all my heart. But she was born and she had significant feeding challenges. She had food allergies. She had FPIES. And at that point, there wasn't a manual to how to treat her. Doctors were few and far between. And it took forever to see them. And I had these questions. And she was already having challenges with feeding. And then on top of that, to have all these food allergies, which made it harder for me to figure out what to feed her.
Yeah.
It was really stressful. And then she was born with colic. So she just cried and cried for hours a day. And it's hard to deal with that. It's hard, especially when there's also the feeding challenges and food allergies.
Right.
And of my sense of stability from a sense of control and from knowledge. So if I have enough knowledge, then I feel like I'm more empowered to make the right decisions. And through that empowerment, I feel safer and I feel more like I can handle this, and I'm calm, and I have the freedom to then figure out what's best for her, as opposed to just spending all my time on that. By the time she was born, I had over a decade of clinical experience. And so I kind of knew what we know about medicine. And the questions I had were outside of the realm of what I knew as a physician. And it's so interesting when you reach the borders of what's known, and you know what the borders are
Yeah.
because
Yeah.
you've seen them for so long, and then you have that
Right.
child, and you're, I have questions, and as a physician, I should know the answers for them, but I just don't know. And so then what do? You reach out to the communities that are experiencing the same thing, because nothing better than having that sense of community, that you're not alone. We're in this together. We're a
Right.
family. And then you also get it through looking at all the clinical literature that's out there, coming up with your own like analyses and your own thoughts for
Yeah.
it. And I think I'm blessed because I didn't just get my MD. I also got a master's in public health and epidemiology and biostatistics. So I can look at research studies and figure things out from them. So
Okay.
then the way I did it is I went through all the clinical literature that was out there. I went on PubMed. I looked at everything having to do with that particular topic, all of it, and I summarized it, and I took notes, and I barraged myself with so much clinical information to be able to figure out, what do we know, what don't we know, what should we know, but just nobody's summarized together in a way that everybody can understand, not just the
Right.
physicians, but everybody. And so I started writing books, because books are way cheaper than copays. When you have books,
That's
you
true.
can
Yes.
you can help people throughout the world, and you can
Right.
give them a lot more information than you can share in a 15-minute visit. And then I noticed with that all of a sudden I had these books with information which I think is up to date, it's relevant, it helps to change fields. And what do? Do I just keep the books to myself, or or do I spread the message? And so how do you spread the message? So you start going on podcasts, you start doing lectures for other physicians, you start going to different locations and just saying, this is the talk I want to do. Let's do this talk together. And while I was doing that, I realized that there were people who wanted more one-on-one consults with me, wanted to talk to me more about what was going on. And I'm like, well, sure, let me do that. And it was easier for me to just say, I want to come to your home. You're probably stressed. If you have some of these issues going on, you probably
Right.
are really stressed yourself. And
Right.
why don't I come to you as you coming to see me? I just kind of made myself available. And then I realized that if I just kept my niche at feeding challenges, food allergies, babies with colic, and some of this other stuff, because I have a lot of other books. Like I have a book about hypercalcemia that's on the table.
Oh,
Like I'm
wow.
constantly writing. And I realized that while I was doing that, I was forgetting about the fact that I'm a family physician. I'd like to do the full spectrum of family care. And if the family really loved me because I was helping their child, why can't I see the rest of them too? And so now I'm in a place where I'm seeing the whole family.
That's so great.
And by seeing the whole family, I'm helping them in different ways. So that brings us to our story from today. Should I share my story?
Yes, please share your story. So we were a little late getting started today because of a medical emergency.
So sometimes you go into homes, and when you're in those homes, people act a certain way when they're in the office. You sit at the exam table, they talk to you after perhaps seeing a medical assistant, eventually do an exam, and then you go home and you have this 10, 15 minutes to see them.
Right.
When you're in the home, they kind of sit wherever they want, wherever they feel comfortable. You kind of see to see who else is in the home as well. And in this particular patient's case, the patient, when I saw him, he just seemed off. He seemed like he was tired. His seemed like it was a little spacey. Was wanting to sit down. He didn't really want to stand up. And I'm like, what's going on?
Is this an
And he wasn't
adult or
really
a child?
This is an adult. This is
Okay.
an adult.
Okay. Just curious.
And he wasn't, yeah, everybody. So he wasn't actually he was just kind of out of it. And I'm like, well, why is he out of it? And as the visit progressed, he seemed to be even more out of it. So then I had to put my clinical hat on and say, well, why is he out of it? Like, what's going on? This is not normal behavior. And like, I didn't know. I just like, do I send him directly to the emergency department or do I try to figure out some of this on my own?
Right.
And I have supplies with me as a physician. So, of course, like your blood pressure cuff, check your blood
Hmm.
pressure, check the heart rate. And then I have other supplies with me as well. So I have a glucometer. I have a point of care hemoglobin A1C test, other lab work that I can do right there on the spot. And I was like, let's just kind of figure this out before I send you anywhere. Let me be a detective. Let me figure out
Yeah.
what I can help you. And so I
Yeah.
checked the sugar because sometimes, when you're feeling a little off, when you're a little spacey, it's your sugar. And his sugar was 30. Now, most of us, just to give you a sense, have a sugar that we walk around with that's maybe 80, 90, 100 milligrams per deciliter. And
Yeah.
his was really, really low. And he had no idea because he was never diagnosed
Wow.
with diabetes, ever. I'm like, your sugar's low. What's going on? So then I did my point of care hemoglobin A1C, and his hemoglobin A1C was really, really high, which means that he has been walking around with undiagnosed diabetes forever. And that's why he was feeling as sick as he was. So he
Yeah.
hadn't eaten breakfast yet today. And he was just kind of thinking, it'll be fast for this visit with me. And it was affecting how he was feeling. And so we made sure he ate lots and lots of sugar, lots of
Okay.
glucose. And then and the sugar was better. So then I started doing diabetes education with him. I actually gave him my glucometer that I have because I
Oh,
was
that's
like,
good.
let's just
Yeah.
do this now.
Hmm.
I could get another one.
Yeah.
Let me see how he is. Let me call him back and give him a log to keep track of his glucose. Let's see what it is. Let's see how things wind up being. And then following up with him to see what I can do next and what kind of
Yeah.
medication he needs
And
to
to
help
clarify
him.
that, you're following up with him later today. It's not like you're saying come back
Yeah.
tomorrow because he may need to
No.
start something today, right? You don't
Yeah,
want him to wake up
exactly.
tomorrow morning with
Exactly.
a
You don't want
glucose
to,
of 30.
that's it. But that's
Yeah.
the beauty of these house call visits. That I'm seeing them at home. I'm spending more time with them because I am my own physician. I have a lot of medical staff that I'm
Right.
with. It's just me to keep the cost down. And that allows me to spend more time and to do the education and to bring
Hmm.
supplies with me that I would otherwise say, go to the lab. But going
Hmm.
to the lab, but by the time he got the same answers he got with me, it might have taken a long time. So there's this
Right.
joy in doing house calls. There's this joy in being there for the patient.
That's
Yeah.
so amazing. He's so lucky to have you and that you were there and that you had your thinking hat on. And it's so interesting
It is.
because
It
one thing I always teach med students and residents, which I was thinking about as you were telling the story, is that our job isn't always to figure out the answer. You figured out the answer, but it's to
yeah, but
know,
that's
is this
right.
patient sick
Happen.
or is this patient not sick? And you knew right off
Exactly.
the bat that something was not right and that it had to be addressed in some
Yeah.
way.
And I think if I have been flustered as a physician because have to see 30 patients that day, I'm not sure that maybe he would have gone straight to the emergency department because I would not
Right.
have had the
Yes.
times.
I've had times where I had to send a kid over to the emergency room and I didn't feel like I even had time to stop and tell the emergency room doc why the kid was coming because I was so busy with the next patient and I had just spent so much time with that patient. That's how it
Yeah,
feels in those busy, busy clinics.
it
And it's not a good feeling.
yeah, it's kind of hard, especially because I want to practice the best kind of care I can. It's super
Right,
important
right.
to me. I
You
like to
are.
lecture to other doctors, and I like to lecture to medical students and residents as well because I'm writing these books. So I've gone to
Mhm.
various residency programs at various hospitals and said, I'm here to present because the
Mhm.
information I'm sharing, the books I'm writing, they make sense. They're going to help to
Yeah.
propel medicine to a new level, like with colic
Yeah.
and with FPIES. Now my
Right.
FPIES book is all over the world. People are calling it a lifesaver in the
Yeah.
field of non-food allergies. And it's all
Yeah.
from having accessible information when you need it, presented in an appropriate way that's as research based as you can get. Yeah.
That's Wonderful.
because
Well, on that subject, so we
okay,
may have
sure.
some viewers today who don't know what FPIES is. Can you give us the like down and dirty, quick kind of explanation of what FPIES is and what it looks like?
So FPIES is food protein induced enterocolitis syndrome, and it falls within these food allergies that
Mhm,
don't at first appear like allergies,
mhm,
because when you usually think about allergies, most of us think the person with allergies has hives, they have difficulty breathing, and they have changes in their blood pressure and their heart rate, and they feel really, really off. That's when you think about like
mhm.
allergies,
Yep.
rashes, breathing issues. And then you have food allergies where you eat, and they usually happen right away, right? That's what we think about when food allergies. Like you eat the peanuts and you get really sick afterwards, and it shows all these physical symptoms. And then there's the types of food allergies where you eat a food and then 30 minutes to 6 hours later, you have diarrhea. That's kind of bloody or mucus filled, or you start vomiting a lot. And you're like, well, maybe that was, it's like most of the time as doctors, when someone has gastrointestinal symptoms, we tell them it's not the food, it's a virus. And patients sometimes are like, no, no, it's the food. And most of the time, it's the virus, it's not the food.
Right.
But there are instances where it actually is the food. And it's the
Okay.
food that's making them sick. And it's giving them diarrhea, copious amounts of mucus and blood in their stool, or sometimes the opposite, lots and lots of constipation when they eat it,
Mhm.
and nausea, vomiting. And we eat so many foods that sometimes it's hard to know which one it is. And because of that, if a person has consistent symptoms when they're feeling off like this, it's good to have food log. Look at actual food ingredients as opposed to just like processed foods or a meal, because the meal is made up of all kinds of ingredients. It's usually
Right.
particular ingredients within that meal that are making you sick. And it could be any food. Like sometimes with regular food allergies, where you have the respiratory symptoms, the skin changes, you think, oh, it's going to be usually your top 8 foods, which might be like your nuts, your milk, your soy, your
Mhm.
fish, your shellfish, and so on.
Right.
With these other food allergies, such as FPIES, which is probably one of the
Mhm.
worst of them, it could be any food. Or sometimes it could be food that we don't normally think of as being allergenic. So, an example is rice. In the regular food allergy world, rice was traditionally considered to be a non-allergenic food. Very few people had allergies with it, or the kind with the
Mhm.
respiratory problems, the rash. And then we realized that when it comes to non-IgE food allergies with these gastrointestinal symptoms, rice is a common culprit.
Interesting.
And non-IgE food allergies usually occur in young childhood with babies and with toddlers, but they can actually start at any age.
Hmm.
And so for somebody who winds up with lots of these digestive symptoms, it's something we also need to be looking at. And the treatment is medication like Zofran to help with that whole process of vomiting. And it's also sometimes food elimination. We just stop that food and we replace it with something else. Could it contribute to feeding challenges?
Oh,
Children are
sure.
more likely to enjoy feeding if feeding feels comfortable to them. Like after we've had an episode of vomiting, many of us don't really want to eat, or we associate vomiting with the food. And so when you're trying to teach children how to eat, because feeding can be a learned skill, and you have this, it makes it
Mhm.
harder.
Yeah. And what I was going to say was just that I can imagine that people with this diagnosis, that it takes a long time, unfortunately, to get to the diagnosis because there are so many
Hmm.
other things probably higher on the list of possibilities. I mean, in 20 years of
Yeah.
practicing, I've never diagnosed it.
And it's actually more realized. So, and
Yeah.
sometimes it's not brought to attention, or sometimes as parents, if when we look at baby stool, because it might not just be FIs, but it could be like these proctocolitis. When we look at baby stool or children's stool, we're like, it's just a variation. where in
Right.
fact it could be something.
So when do you worry? I mean, let's say you've got a baby who eats fine, not fussy, no colic, no obvious allergy symptoms, growing, thriving, but has mucousy stool, mucousy green, frothy stool. When should you start looking at that more? I mean, should you look into it if everything else is fine?
So when it comes to stool, we have different kinds of stool that doesn't look good, right? So if there's blood in
Right.
the stool, if it more looks like snot, like there's lots of mucuses of it as opposed to actual stool, might be a problem. And then there's lots of babies who walk around like this with this kind of stool, and then eventually as the food allergy resolves, the stool resolves as well, and no one thinks anything of it. And they grow just fine, but maybe are more fussy. I wrote the book about the colic handbook about babies who just cry and cry. And one of the differentials in there is babies who just cry and cry and cry. Maybe the reason they're really crying is because of some food allergies. Like that is a potential differential for colic. And you have a child who's otherwise thriving, is growing, is not giving you feeding challenges, and just has these changes in the stool, we might just kind of ignore it. But could these changes in stool potentially lead to the child having some kind of nutritional deficiencies as a baby? We all know most of the time we don't do this huge nutritional workup on a baby. But if there's inflammation within the digestive tract, which is who might represent, could there be some changes in some of the minerals, electrolytes, vitamins for the baby? Maybe. We're more likely to work things out as physicians if there's signs of difficulty with feeding, if there's major difficulties with feeding. Different organizations have a questionnaire, like Feeding Matters, for instance, has a questionnaire that asks you about your child. How is their feeding? And based upon how you answer, you can have a sense of, is this fall within normal limits? So what's considered normal feeding? Or is this something that you should be worried about? Is this abnormal? So you just plug in your information on the Feeding Matters website and you'll come up with that answer. If the child is having failure to thrive, they're not growing appropriately, that's another place of concern, because then you worry maybe it's and if there's a lot of vomiting sometimes, like the vomiting, it's usually babies who are vomiting all the time, you have to feed them all the time just to kind of get them to gain weight. You might want to look at that because it might be more comfortable if they're not vomiting all the time. Now, there's a difference between vomiting and spit up. So spit up is when it's just like a small amount of food, or a small amount of digestive stuff, a small amount like saliva, mixed digestive things go ooze out of the mouth. And then vomiting, which is more projectile, winds up going on the floor, it winds up going in the hair, clothes, on the kitchen counter, whatever. And so spit concerned and vomiting.
So, I mean, I guess the take-home point there is if there's something that is persisting, and especially if there are whole things that you're noticing, weird poop, but also fussiness, weird poop, but also vomiting. Again, it's persisting. So it's not like, with a virus, we're going to see symptoms for a few days or a week, and then it's going to go away. But these things persist, or they keep coming back.
Exactly, or they seem worse, and you have moments like with FPIES, some of these children, they become almost like listless, where after they vomited so many times, they vomit, multiple episodes, and eventually they don't look like themselves. They're not active, they're not playful, they look really tired.
Yeah. Well, I'm glad to know, and that's, I think, helpful for parents to know too, that there are tools out there, and I'll put those in the notes, that can help you to, at home, be reassured, or to know that you need to really bring this up with your doctor and find somebody who's going to listen to you, and find a DPC doctor or a concierge doctor who's going to be able to spend the time with you.
Of course.
That's what you need, right? Well, I know that you actually have an obligation in like a minute, and so do I. So we
Yeah.
unfortunately have to cut this a little bit short, but we're going to do another one because we can't really leave it here.
Yes.
Um,
Pretty
so we
much.
got a
For
little bit
having me.
of FPIES information, a little bit of an exciting home visit story with this
Yeah.
amazing doctor who just, totally helped this person. Oh, we lost her. Well, thank you for joining us, Dr. Eva, and all of the viewers. And I hope you have a wonderful day. And definitely, we will let you know when we're going to do our next. Oh, there she is. We totally lost your picture there. I'm just touting all of your wonderful qualities and reassuring people that we will talk more about any of these issues. And please put comments or questions in the comments section and we'll look back and answer any of those that we can. Well, thank you so much. I want to let you go off to your obligations, but let us know later. I'm going to worry about your patient, so let us know that he's doing okay.
Thank you for understanding. You're an incredible physician too. Thank you for all you do.
Thank you.
And we'll
We'll talk soon. Absolutely.
Bye-bye.
All right.